everyone, and welcome back to episode 49 of Core Consults RX podcast. I'm Mike Corvino. With me, as always, Cole Swanson, and today we have a super special guest, Dr. Neha Patel.
Hi, everyone.
Neha, what's going on? How's it going?
Good. How are you guys?
Living the dream.
Doing great.
So we've been trying to get Neha on here for a while. I've heard from multiple students at the Medical University of South Carolina that she's a genius, and they've gone on and on about how smart she is. And so we definitely were excited to get you on here because, with everyone applying for residencies and whatnot, kind of right now and thinking about interviews and whatnot, I think you got some good insights since you've spent a lot of time in that world, obviously. So hopefully we can pick your brain a little bit.
So no pressure. So you can either steer people in the great direction or you can just steer them wrong.
That's good.
Yeah.
That's good.
I'll try to steer everyone in the right direction.
Okay, good.
I
wouldn't. Yeah, I'd go the other way.
And if not, you know what? We got to learn somehow.
Exactly.
So tell us a little bit, kind of about yourself. How did you decide on pharmacy in the first place?
Well, actually, I didn't want to be a pharmacist because all I knew was Walgreens. For all you Walgreens listeners, really sorry about that. Somehow my parents thought it would be a great idea, so I ended up in pharmacy school, and I don't regret it. I think it was when I started rotations that I realized I could do more with it, and that kind of geared me into doing more of a clinical practice. I went to St. Louis College of Pharmacy and did both my residencies at the Medical University of South Carolina in Charleston. I got into transplant initially because I wanted to do critical care. And that's a very saturated job market. And I had one transplant rotation. I absolutely loved it and kind of got experience in both critical care and transplant. And that's kind of how I ended up with a career in transplant.
Awesome.
That's cool. So what were you thinking before, they kind of pushed you towards pharmacy? What was your goal when you were younger?
It was to be a dolphin trainer.
Oh, yeah.
Seriously?
That's what I'm talking about. That sounds way better than being
I think
a pharmacist.
everybody's secret dream is to do something with marine animals. Like if I could go back and it didn't matter what I did, I'd probably do marine biology or something.
Right?
Yeah.
Yeah.
Way better.
It does sound pretty awesome. Mm-hmm. I would find a way to I'd be eaten by a dolphin, first person in history.
Well, you'd probably do some with the reptiles, I think.
That's true. I would.
Yeah.
But so and that's kind of funny that you mentioned that because about your idea of what a pharmacist was. I'm always still kind of shocked by that in this day and age, I feel like the majority of people, when they think of a pharmacist, they only think retail pharmacy.
Very true.
That's, ugh.
Well, when you think about anybody's exposure, general exposure to pharmacy, it's going to be in a Walgreens or CVS for the most part. So growing up, even if you want to be a pharmacist, it's probably what you think, unless you have a family member or friend who does transplant or is doing something clinical, or even if you experienced one in a outpatient clinic setting or something like that.
Yeah, and I say ugh, not to offend anybody. I was a community pharmacist in a retail setting for a long time. Cole still is, so I'm trying to be offensive. I think that because of the way everything's changing, I don't see retail pharmacy as being this sustainable model for a long time. I've said that several times on this podcast, and I want the next generation to kind of see pharmacy for what its potential is, not for only the retail setting. So don't be offended by my ugh.
I think Walgreens is actually getting into the mail order pharmacy world.
Like a specialty?
Yeah, with I think they're teaming with FedEx or something to do one-day delivery. And CVS is teamed with USPS or something, all to fight Amazon and PillPack.
I was going to say the problem with that is the fact that they did that as a defense against Amazon. If I wish they had done that 10 years ago so they could have the bugs wired out, because Amazon certainly has no problems with shopping or mailing and shipping and all that, and so Walgreens and all them still have to work the bugs out, and it takes a really long time because they're so big. They were very reactive and not proactive, and I feel like that doesn't matter what they do at this point. All Amazon has to do is jump in the game. So just gonna get that on the record in case I'm right.
Put some money on it.
Yeah, sure. I got $10 to spend. Okay, sorry, that was totally off subject. But so when you were in pharmacy school, what were you the type A straight A student? Or were you just the person who didn't have to go to class and you just were super smart?
No, I was not the person that didn't go to class and was super smart. I was the type A person that had to study. And actually, I didn't have a lot of exposure to transplant in college. I think we had one lecture, and that was kind of it. So all my exposure to it was post training or post pharmacy school. And the only little bit I knew is we had a family friend that had a kidney transplant. So that was kind of my first exposure, but I was still fairly young when that happened. But not a straight A student, but decent grades.
So it was during your PGY1 that you decided to go for transplant away from critical care?
Yeah, it was right towards the beginning of it.
And you're able to stay on with the MUSC and finish that up too?
I was able to stay on, and so that's part of the reason as well. And I liked the team I worked with, so made it easy.
Yeah.
How common is that to have a resident that goes both years of residency and then stays on at that same teaching hospital? I feel like that's pretty hard to do.
It is. I think to stay on as a clinical specialist or pharmacist at that institution is hard. It just depends on what's open and what positions are open. There was nothing when I finished my residency. I just came back a few years ago. But I think with more and more requirements for transplant pharmacists, I think there's going to be more and more positions opened. I think there are going to be a lot of centers that expand their services, and a lot of people kind of trying to create some new positions for transplant pharmacists. But it is there's a lot more residencies than there were when I was a resident. So it's growing, that's for sure.
Is it growing because transplant in general is growing, or just the appreciation of pharmacists in that setting is growing, or both?
I think a little bit of both. I think in regards to numbers of transplants, they're probably more stagnant, but I think it's more the services and resources that we provide to transplant centers, and that's why we're growing.
Yeah.
So kind of when you were looking at, different residencies and whatnot, walk us through, briefly, like, what was your, I guess, strategy going forward? You hear all these different tidbits that you give students of what to do to kind of set yourself apart from the crowd. Because, like you said, residency programs are growing, but also is the desire to go to residency. And so what would be some advice for students listening that are thinking about that, since it's this time of year? If they get a call for an interview here in the next couple of weeks, what should they be expecting to do?
I think the interview process has changed probably from when I was a resident. I think a lot of programs now do a lot more behavioral type of questions, which is probably different than what was done when I was a resident. I think some of the other centers also do a lot with either cases or some sort of almost like a test when it comes to kind of screening candidates. So something to be prepared for, which you should know ahead of time. You just aren't obviously going to know your case ahead of time. But I know where one or two programs I'd gone to had a case that you had 45 minutes to complete. I think the other thing that was a little bit alarming to me when I first interviewed was that you're usually interviewing with 6 or 7 people. So there's also 6 or 7 candidates there. So you're kind of crossing paths with potential people that are competing against you. And you're also interviewing a lot of times in panels as opposed to just one-on-one, which sometimes can be a little intimidating. So just to be prepared for that. The other thing is you can Google a whole bunch of behavioral questions, but be prepared to answer some of those throughout the process of the interview. And then some of the big things is why you want to be at that program. So make sure you have a solid reason, and don't ask questions that are already on the website.
Oh, yeah, that's a good point. But I think Brian Gilbert mentioned that too.
About that.
So one of the guys that's been on here a couple times, a critical care pharmacist out of Kansas, named Brian Gilbert. He was telling me that they got a paper published on it, but they did an escape room for the group part of the interviews, and they built like an escape room in the hospital, and the students had to work together to break out of this thing. I thought that was awesome.
Yeah. And he did a paper on it, which
and got cool. Yeah. I think if I saw that, I'd be like, please let me come here. You guys are awesome.
That's pretty cool. That is a good way to show teamwork for a program.
Yeah, especially when you're all nervous, and then the like when we did the PA interviews just to get into PA school, and they had to like build like a tower, of balloons. It was something very arbitrary, and there really was no right answer. We just want to see how quickly the personalities come out is pretty interesting.
Well, it wasn't residency, but for pharmacy school, one of the schools had like the whole group choose. There's like a list of items, and you had to choose like 3 that you would take to a deserted island or something like that.
Oh yeah, those are good ones.
I don't know. I didn't love it, but maybe that's just me.
I would just pick the 3 most ridiculous, random things, and then just see if I could improv my way through like why I would actually bring those. Just feel like, what is wrong with this guy?
Balloon animals.
He's making some good points though.
Oh, balloon animals. That would be a good one.
Yeah. One of the people that I'm assuming I'm allowed to say this. One of the people that interviewed for and got was in that group for the PA school that was trying to pass the balloon tower test had been a professional or a very high level like animal balloon person and just crushed the competition.
What are the odds?
Oh my
He's
gosh.
like, yes, I knew this would come in handy.
I told you, Mom. Oh man, I didn't see it myself, but I had heard about it later, and they said his tower was amazing.
So he's basically a clown.
Yeah.
He was a clown at some point.
How dare you? He might have done it at the
That's a
children's
very
hospital for all you know.
That's a respectable profession.
It's scary to some people.
That is true.
Yeah. Clowns are kind of freaky.
Yeah, they
especially.
can be.
Thanks a lot, It.
Yeah, I know. It's all Stephen King's fault.
I know. Never trusted that guy. Anyways, what are some like absolutely? You mentioned a great one, which is don't ask questions that are on the website. That would be hilarious. But what are some other like absolutely don'ts? Do you have any that could come to mind? Like if you were conducting interviews?
Yes, I think some, obviously salaries don't just because you're a resident. I think another big one that comes up is staffing. So how many weekends and whatnot you work.
Brian mentioned that too, I think.
Yeah, those are things that shouldn't make or break your program choice. So those are things pretty much not to ask
Yeah.
throughout the process. I think there's things that you can ask about. There's programs that take call and how those kind of systems work. But in regards to just the weekends and whatnot, those are probably questions not to ask.
Right. So it just makes you sound
Yeah.
lazy.
Yeah,
Like,
pretty much.
I have to work how many weekends
Right.
during 1 year of my life?
Right.
That sounds awful. Yeah, I'm always fast, especially like when you see some of the residencies that, if you were to actually be like a transplant surgeon, how long you have to get a residency.
Right.
I'm like, yeah, okay. I get it. It's a really hard couple of years, but it could be 3 times longer.
Could be.
So, yeah, anyways. So when you kind of made that transition from student to a resident, what was some of the, like, I guess, hardest parts of that? Like, was that an easy transition for you, or was that like, because I feel like that's a big jump from when you're on rotation as a P4 and, you always have 15 people above you that you can ask questions to, even if you're the one, quote unquote, making recommendations. How is that being a resident where sometimes you are the one rounding?
So I do think it's a big transition because you also go from being a student straight to a pharmacist. So you do have a license, which is always kind of scary. So I think the transition is, you can make it what you want it to be. I think you have to remember you always have resources and you have preceptors to go to. I think the biggest challenge is for the practitioners that think they go straight from student to residency and all of a sudden they know everything. Those are probably the most dangerous individuals. So I think just knowing your limits is probably the biggest thing. And also the things that you learn in residency is so much different than what you've learned in school. It kind of puts everything together. There's going to be so much during residency you see that isn't something you learned. So everything is a learning opportunity as opposed to a test on whether or no you know the answer. A lot of it is your ability to find an answer and how you go about it as opposed to actually knowing it right off the top of your head.
Yeah, that's a good point too, and I think that's in really any setting too. Sometimes I'm always kind of shocked when if I ask a student something, and then like if they don't know, it's kind of like, well, they don't really necessarily know where to look. I'm like, there's so many resources there, and I think that's such a humongous opportunity for growth personally. And when you get out of school too, is having those resources already set up and knowing where to look, and continuing to grow that way, because there's no way you could possibly know everything about even a small portion of medicine. So,
and I guess students can take comfort in the fact as well, transitioning, that even though you are a pharmacist and you do have to make decisions, if you're in a significant bind, you can always go to a preceptor and get another opinion. Right?
And there's a lot of times that we get asked questions and we don't know the answer, and it's figuring it out and finding resources to help guide that answer. So I think that's also a learning thing that we as preceptors also don't know the answer all the time.
How does it work? And this may be an ignorant question, but in regards to a pharmacist role, because there's so many different types of transplants, do you have to actually specialize in a certain type of transplant, or is it just transplant in general?
So most programs are transplant in general, so it just depends on each center and what that center particularly specializes in. So when I was a resident, my training was primarily kidney, liver, and some heart. I had no experience with lung transplant because we didn't do them. I took a job in lung transplant and somehow managed to learn it.
Nice.
in a high volume center for that matter. But now our program does all organs, so it's kind of nice because our residents are kind of well-rounded. But there are centers that just do abdominal, and there's centers that just do thoracic. And I don't think that means that that's the only organ you can function in. I think it just teaches you the baseline, and you can carry that forward to other organs.
Right.
I think if you're trained in solid organ, you can probably pick up any organ. It just takes a little bit if you're not used to it.
What was the hardest thing for you as far as transition from PGY 1 to 2? And was it a kind of a real smooth transition, or was there a big switch?
I think for me it was relatively smooth because it was at the same center. I think there's plus and minuses with that. I think one, the advantage is you don't lose a month of orientation. You kind of already know the system. You don't have to train. I think all those are big advantages of staying at an institution. Obviously, if you go somewhere else, you learn different practices. You meet different people, which I think is equally valuable as well. I think the biggest kind of transition, though, going from a PGY 1 to PGY 2 is oftentimes as a PGY 1, there's a little bit more kind of hand-holding. And when you get into your specialty, it's kind of you're almost thrown into it with support. But staying at the same program, you're kind of just expected to know some of the things and the routine things that kind of carry on from day to day. I do think the learning curve is much different, but I also think it's more fun because it's what you're going to be doing. So, it's what you chose to do for an entire year. So you're not doing some of these rotations that you don't care for that are required. Your 1 year is primarily focused on what you're going to do.
So it feels a lot less scholastic and more like
Yes.
you're actually doing your job now.
You're doing your job and you're learning and you're starting to become a practitioner. Because I think when you're on rotations as a PGY 1, it's great. But by the time you get into the swing of a rotation, then you're ready to shift into the next rotation.
Kind of like P4 year.
Yeah, so right when you figured it out, especially for some of the more complicated rotations like transplant or any of the ICU things where you don't have a lot of that in school, by the time you get in the swing of things, it's ready to move on.
Right.
So kind of walk me through, like, when you finished, residency and you actually got your job, and, I from what I've heard, and I've heard this from multiple people, you are extremely well respected by the attendings as well, that they go to you for everything, and, anything med related, they're calling you up and bugging your phone 24/7.
Mm-hmm.
And, how did you go about? Did it just kind of happen over time, or because one of the big, I feel like, struggles for a lot of people, and as pharmacy kind of progresses, pharmacists in general, are still trying to find, earn the respect, I guess, or you'll see some people that just want that respect as a PharmD because they have some letters after their name, but MDs and whatnot don't always reciprocate that. And so how did you kind of navigate that aspect of it?
So I think when I first started, when I went to a different institution, it's a little bit more difficult just because they don't know you yet. I think the big thing is to prove yourself. I think the other big thing is that you need to prove that you work just as hard and kind of be available to them for questions and whatnot. And I think you have to be willing to bring something to the table when you're first starting out. I think when I came back to MUSC, I think it was just one of those things. They already knew who I was, so it's an easy person for them to contact. But I think the biggest thing is to be able to know what you're doing. I mean, if you have no clue what you're doing, they're not going to respect you. And I think it takes time when you come into a new center. The one advantage, I think, is that as more and more programs are having residencies, I think providers are seeing what we actually can do and what we offer, because there is somebody that is always on service, or there's someone that they can kind of call, and I think that helps. So an institution that's been used to pharmacists, I think, gets that respect a little bit quicker than institutions that don't necessarily have that.
So what attitude do you think would work better in those beginning stages? I know what I'm doing, so I'm going to push my recommendations on you and prove to you that I know stuff? Or is it more like, I'm going to sit back and observe and let you come to me, and then when you ask me questions, then I'll prove to you that I know stuff?
I think it depends on who you're working with. I think medicine is different than surgery, and I work with surgery, so I think, I work with a lot of hot-headed people, or I used to, not so much anymore. I think surgeons have also come around the corner a lot, and they're very different to work with now. And I think with them, it's more of you don't have 30 minutes to explain yourself. So if you want something done, here's why. prove it to me, and call it a day.
Yeah.
On the medicine side, I think you need to prove, you have more time to prove yourself, and they want to know more in detail all the things that you're talking about. So you have 20 minutes to say, well, this study showed yada, 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 and this study showed, and that's what they want to hear.
Yeah.
But I also think with any new job, probably the first couple of months, you kind of sit back and you just kind of take it all in, as opposed to walking in on day one with this power trip.
Right.
The other thing is always remember there's more than one answer. So no matter how much you think your answer is always right, there's multiple ways to do it.
Right.
And so the more you push for your way or no way makes it more difficult.
So know your audience.
Know your audience.
That's good. How have you gone about like staying current, like with new recommendations and guidelines and studies and whatnot? Do you have a certain strategy that you use to stay up to date with everything? Because I feel like that's a ever changing world and research is kind of constantly coming out. So
Yes, it is ever changing. I do actually think residents and students kind of help with that because as they're reading about topics, they're bringing new things to you. I think one of the easiest ways is to sign up for table of contents for journals that are pertinent to your path. So I have a lot of transplant journals. So you get one email a month that gives you the table of contents. So it's kind of nice for you to peruse and just see what's out there. And so at least you know what's coming out instead of kind of looking for it. It's coming to you, which I think is a nice way.
absolutely make the process automated.
Yeah.
That's cool. Yeah, I definitely agree. I think did you start doing that like because I always advocate for people to start that even while they're in school, like having articles. I've heard students be like, well, I'll do that as soon as I get out and, I'll start kind of paying attention to the new information and whatnot once I finish school. Because right now I already have all this new information coming at me. So I personally usually advocate for them to spend like 5 or 10 minutes a day reading something that has nothing to do with their curriculum to just get in the habit of it. So then when they do get out and they have more time, it's just kind of a natural part of their day. What's your thoughts on that for students?
I think that's a good way. I mean, I started this year, which I think has helped my own residents. Instead of spending hours upon hours a week doing topic discussions, is you pick one article a day that you're going to read and we're going to talk about it. So, it usually ends up being about 3 times a week, 3 to 4 times a week, but nothing extensive, but it's something either that you found, something that was patient related, to kind of build their library and kind of keep them reading as well. I think that's a big thing that people forget, that, once you feel like you've learned everything, you haven't, and there's a lot to learn. The one other strategy, which I tell my residents now, which wish I would have done on my own, is if you're still in the age of printing and writing notes, it's probably best that you upload those as the article instead of your regular article, so that way you have it later with your notes. So something to think about doing if you're not doing that already.
I usually carry a backpack around with me with just all my hard copies.
Yeah, with all your hard copies, yeah.
People laugh at me, but I don't care.
Got them all back. They're filed away and you can find them quickly.
No, I can't. If I actually had something like that, it'd be the most disorganized disaster you've ever seen in your life.
Yeah.
Just a bag full of papers.
Yeah, I can't even barely organize it on my iPad, let alone actual physical papers.
Yeah, so have some organization method.
That's for
Whatever
sure.
works.
I get the whole, like, people are like, I just like to feel the paper. I'm like, okay, I got it, but just feel your iPad.
Yeah.
Just feel your iPad.
And if you like the paper, then write on it and then upload it.
Yeah.
And therefore,
for
it's
sure.
like there for you in the future.
Yep.
With all your notes on it.
Or get Notably. I don't know if you guys have used that yet. And you get an iPencil.
Is that the annotation?
Yeah. You can change it to look like pencil, which is cool. And then it feels just like a regular.
Not everybody can afford the iPad Pro mic.
You could go garage selling and flip some stuff to find enough to buy an iPad or a pencil for the iPad. Anyways.
Mike has all the stuff.
I like tech toys.
If it's out there, he's got it.
That's not true.
Mostly.
But is it cool if we kind of go through some of these questions a little bit from Insta?
Yeah.
So pulling them back up here. I put it on Instagram just to see if anybody had any questions. But the big one that people keep, a couple people have asked about now, is pain management in transplant. Got some thoughts on that, perhaps?
Yeah, pain management seems, so first, the pain management thing is kind of all around, not just for transplants, become a hot topic of managing opioids and whatnot, and likely a lot because of the opioid epidemic and patients just dying because of overdoses. So, there's a lot of emails that have been going around on how to manage pain and what centers are doing and whatnot. And so we've recently changed our kidney transplant protocol. Previously to September, I guess we changed it September 1, all of our patients went home on 60 oxycodone, which is a lot for, not a minor surgery, but not a major surgery. So there's a lot of centers that send them home on nothing. And so we thought we'd get on that bandwagon. So we've had a lot of things where we've given them nerve blocks and we use scheduled Tylenol and gabapentin. And so far that's worked pretty well. Our patients that are chronic opioid users, they kind of go home on opioids because we're not going to break that habit in 3 days for them. But for the most part, we've looked at our initial numbers and we've only sent home a few handful of patients on pain meds. So I think the big thing with it is it requires a lot of buy-in. So it requires a lot of buy-in from everybody on your team. So nurses being big, kind of advocates and kind of explaining to the patient what we're doing, the things that are in place, and kind of really assessing their pain as opposed to just kind of getting this arbitrary number. So that requires some time. I think the biggest buy-in or the hardest people to kind of rein in are the residents because they just like to hand out things like that when people ask for it. But with a lot of education, I think it works. I think, if you can educate patients ahead of time, I think it's very helpful. I just think the time it takes for somebody to get on the kidney transplant list and then transplanted is years. So if you educate them 4 years ago, they're not going to remember anything. But I think the big thing is education and why we want to be doing it and telling patients the concerns of narcotics.
So these are kidney transplants in particular?
Yeah. Our other organs still go home on narcotics. They're a much bigger surgery.
Gotcha. So kidneys more. To me, that seems like a good procedure, but I guess relatively speaking.
Relatively speaking, it's a minor procedure. The rest of our organs go home on pain meds. Most of the time, at least for liver, we say that first fill is all you get. Every once in a while, we'll fill again, but for the most part, they get the 60 tablets, and that's it.
So some people have mixed feelings about gabapentin for various reasons, but it works for this?
Yeah, it works for this. It's there's a lot of studies that say they get these big doses prior to the OR, and they get a big dose before they go to the OR, and we titrate it as need be, as on the inpatient side, and our kidneys leave on post-op day 3. They get 5 days worth of gabapentin, and most of them don't ask for refills, don't ask for more. The only patients that we kind of change are patients that were on chronic gabapentin. They obviously stay on their chronic gabapentin for whatever reason, or Lyrica, whatever they were on. But patients that are completely opioid naive usually do okay with it.
And plain Tylenol, not with codeine?
No codeine, just plain Tylenol.
Wow, that's fascinating.
1 gram Q6 scheduled.
So cut my kidney out, replace it, give me some gabapentin for 5 days, and good to go.
You'll be good to go.
That's fascinating.
Versus Percocet for a filling to get at the dentist's office.
We'll give you a nerve block too on the way, just in case.
That's funny.
That's crazy.
Yeah.
That's awesome, though.
Didn't you say that? I think this was you that was telling me this. Wasn't there like a surgeon from another country that came in and was like stunned that we were like using?
I think I don't know if it was me, but I think there's a lot of places that are very alarmed with what we do. I do have an ortho surgeon that I know well that does mission work in South America, and they don't do pain meds. They're not available.
Yeah.
Right.
For these massive operations, and they get Tylenol.
I think Chris Pie 5 and Tylenol.
Chris Pie 5.
That's how it rolls.
Yeah. No. Respect.
Yeah.
That is interesting, especially with such a opioid epidemic being talked about in every area of medicine. I feel like that is cool that you guys are doing that. Is there any? Do you know if they're looking at like duloxetine or Lyrica or any of those in particular to gabapentin or comparing them, or is it just always gabapentin seem to be the go-to right now?
I think the go-to seems to be gabapentin just because it's got a short half-life. It's not controlled. It's easy to get. Lyrica is still controlled. So that's why we haven't been using Lyrica. Mm-hmm. If our patients are on Lyrica, they stay on it, obviously, and we don't switch them. But as a just go-to med, gabapentin.
Cool.
Yeah.
So we got another question from from Philip. He's actually a student at the medical university, but he was asking what kind of I guess barriers do you have post transplant? Like, what are the biggest challenges you have? Is it like keeping patients on their medications? Is it follow up? What kind of things drive you crazy?
I think for the most part, I mean, they go through a lot of screening prior to getting listed and whatnot, and obviously things fall through all the time. But for the most part, our patients do come to clinic. We do have our handful that don't. So I think the most frustrating part is the patients that don't value what they have. And you don't see that a lot, but you do have your handful that take it for granted, that don't come to clinic, or their social system falls apart, so they have no ride or they have no meds, and because of that, obviously their organs start to fail. But if no one's notified, we can't help them.
Right.
And there's a lot of resources to that can be used for some of these patients. But I think that's the most frustrating part. Is for the most part, people value what they have, but I think there's a small handful that just take it for granted.
Yeah.
Another question asked did you kind of do your first year of residency, was it just very general, or were you on like a track that kind of pushed you towards more critical care transplant type rotations for your first year before you went into your specialty?
So I think when I had done my first year, I had kind of tracked it to be a little bit more critical care based. Mm-hmm. So I had a lot of critical care rotations. I had 2 transplant rotations. So I kind of did make it a little bit more transplant critical care based, which I think helped.
Are there residencies available that are basically like 2-year specialties, or does every one of them kind of have a very general first year that you can maybe tailor a little bit, but still pretty general?
I think for the most part, they're pretty general. I think the couple of the 2 years are like an ambulatory care one, and your first year maybe has, most places require 1 month of ambulatory care. I think if you're that ambulatory care specialty kind of 2-year program, I think you have a couple more months of ambulatory care. Same with management. I think there's a 2-year management one that also kind of tailors it more to management and a little less clinical your first year. But for the most part, I think they're all pretty general with their required ones for each center.
Now that you've kind of been doing, liver and kidneys for a while, do you feel like you could jump into, heart transplants or lungs or anything? Is it pretty easy to kind of go to a different area, or is that like completely different thinking and different process and all that?
I think it's relatively easy. I mean, easy
yeah,
is a loose term.
Right.
But I've done a lot of lung transplants, so it's easier for me to jump into it. For the way our current system works, it's kind of nice because we do cross cover, so we do have exposure to all organs. That those 2 are not my primary organ, but I can jump in and kind of at least have an idea of what's happening. And we're kind of all involved when it comes to protocols and updating all that for all organs, so we kind of stay up to date, which is kind of nice.
That's cool. Mm-hmm. If you had to switch, or I guess if you just felt compelled to switch to something like, I don't know, ambulatory care or something like that, would you have to basically go back, and since you don't do that primarily, do you feel like you'd have to basically go repeat another residency, or would you have to just kind of get on the job training? Like, I'm asking that just because I do have people every once in a while, not so much they're in a specialty to go out, but people who didn't start in a specialty and then want to maybe specialize at some point. So I guess from either way, but what are your thoughts on that? Like, do you think going back and doing another residency is a thing, or was it more on the job training at that point?
I think after years, I think on the job training could work. I think if you're in this completely non-clinical realm and all of a sudden want to jump in, I think going back to do a residency is probably the most marketable way to go back and get a clinical job.
I know that was a super weird question. I just kind of like, it came to mind, and I was like, it just came out of my mouth. So sorry to put you on the spot, but I was just curious.
Yeah.
And I've had friends of mine and stuff that are practiced for 3 or 4 years, like in just this dispensing role at a hospital, and then we're like, you know what, doing residency now, and they went back and did it.
They have some non-traditional residencies that do that, where you're kind of working and doing a residency at the same time. So it's taking you 2 years to complete a PGY1.
I saw some of that in peds when I was at MUSC. Some people do non-traditional.
Yeah, I think one of them is a peds pharmacist
Yeah.
that was doing it. So that's something I feel like that's kind of coming up and about as well.
What about, is there a board certification of any kind for transplant?
Oh yes, it's coming out.
Is it? Are you
Yeah.
getting it?
It's new on the block.
Are you going to be the first one at MUSC?
No. I can't. I think it rolls out in either 2020 or 2021.
Are you super psyched?
No.
Don't want to take a big test.
Come on. Because you have your BCPS, right? So
Yeah.
now you can get all these extra letters.
I've-
No,
all
it's
the
just
letters.
extra money that I'm dispensing
No.
to
What?
somebody.
not
What
cheap.
nonsense? There's no way that's
It's a
it.
money-making scam.
There's no way
Come
that's
on.
it. How
Yes.
dare you?
I've been practicing for 10 years. I don't need a test anymore.
That's true.
We're going to sponsor you for the test just because I want to see it. I'm just kidding.
Yeah, we'll give out the Core Consult RX scholarship.
Sponsorship to board certifications. We actually probably have a lot of applicants.
Free money? Oh, yeah. we have
we'll
some
take that.
applicants.
These idiots are going to give us money.
There you go.
But I was thinking about that because I've seen critical care and all those, but I hadn't
Yeah.
thought of a transplant, so they
Yep,
finally got
it's
around
coming
to
out.
the right one.
It's coming out.
Would you ever want to be involved in actually writing one of those type exams?
I think it'd be fun.
Yeah.
That'd be hardcore. How the heck do you get to be that level? I
I don't know.
I think you'd be surprised at who writes them.
Yeah.
I don't think it's not like some super special. They just you know the people.
just know
and-
a guy.
Yeah, you know a guy.
I know Bill.
And
He's
write
gonna
'em.
let me write some questions.
He's going
Yeah.
to write these questions. I'm not even a pharmacist.
I'm really banking on that. Pretty much my whole career is just meeting
Just
Bill,
knowing people.
just knowing people and being like, I mean, I don't know, he's kind of fun to hang out with. I guess we can let him help.
Yeah, there you go. That's how it rolls.
So I've made a living at that. So
So before we finish up, take us through day in the life. Where you start. Does every day generally the same, or do you swap floors? Like I don't know, every day.
For me, generally, it's the same. There's 3 of us that do transplant. We kind of have our homes, and then we rotate a little bit, but we kind of stick with our home. So I primarily do inpatient most of the time. I do a couple months of outpatient, and I also have clinic days kind of while I'm rounding on my service. So usually, if for example tomorrow, I'll come in, I'll look at my patients, I'll have clinic in the morning. I round at some point during the day, whenever that happens. We do a lot of kind of the, obviously, medication management for our inpatient service and our clinic patients. We do all the drug monitoring, all the follow-up that's kind of put on us to do. All the lab ordering is kind of on us. We also have, just based on CMS type of things, we have certain requirements. So there's a certain amount of documentation that needs to go in the chart and whatnot. Some time for teaching because I have a student, so that'll happen. So yeah, each day is kind of, it just depends. Sometimes it's really busy. Sometimes it's kind of slow, which is nice. I kind of like the mix of seeing inpatient, outpatient. It kind of gives us the opportunity to see the patients that are doing well and kind of be able to follow up. And the continuity of care, oftentimes, our surgeons rotate every week, so we're kind of the only ones that
Stick around.
stick around and keep track of the people that have been there for a long time, which is kind of a nice perk to the job.
Right.
I think that's why they rely on us so much, is because we're the ones that are there
Right.
all the time.
And you have a student pretty much year round and residents as well.
We usually take 4 students a year on each side of the street, so on heart and lung and abdominal.
Gotcha.
And then residents, for the most part, we have a resident almost every month, whether
Gotcha.
it's our own transplant resident or,
PG11
yeah,
rotating.
yeah.
Cool.
what for your clinic days? Are you just like following up with the patient to see how they're doing in general, or do you have like a collaborative practice to where you can change doses and represcribe, or how does that work?
So we don't necessarily have a collaborative practice, but we kind of function like that. So I primarily, when I'm inpatient, do liver clinic. That's like my home, per se, home base. So we usually see the patient, then our nurse practitioner will see the patient, or our surgeon, whoever. So we'll kind of go through all the meds. We'll adjust things based on labs if we need to. We have kind of full authority to do things for like a primary care medicine. So like blood pressure, all that, they let us do whatever
That's cool.
we want. And then we'll follow up on drug levels with the coordinator after clinic, and we can adjust accordingly. So we get a lot of autonomy, which is a great kind of a
Yeah.
fun thing about transplant, I think, which is unique, which makes it a lot of fun.
Awesome.
That's awesome. Cole, you got any other questions or anything?
Unless you want to throw in a sound effect just because we can.
Ooh, that was a long one.
That was a long one.
See, Neha, you don't have that kind of quality in just any podcast.
No, you
No,
don't.
you don't. It's a lot of fun.
The Insta guys are probably like, what in the world are they talking about? Because they can't hear that, can they?
No, probably. No, they definitely
just
can't.
on the
They're
recording.
just like, why are they just looking at each other laughing? Yeah, so if you're watching on Instagram and you think we're weirdos, that's why.
We're basically children.
Yeah, it's true. It's a good point. But yeah, so Neha, we appreciate you being here. It's I know you're busy, so I appreciate you taking the time to do this. It was fun. And then if you guys have questions or anything like that, then send us an email, and I will, if they're good enough questions, maybe forward them on to Neha and see if she can get you some answers. So our email addresses will be in the show notes, and then the descriptions, if depending on what platform you're looking at. But reach out to us, and if you have other questions in general, you can reach us on any of the social media platforms, any podcast platform, and then if you do follow, throw us a subscribe. It would really mean a lot to us. And then we look forward to hearing from you. Thanks for listening. We'll catch you guys next time.
Thank you.